I'm going to give you a short, brief talk about my experience with COVID-19 in Chicago. Here you see my son, gastroenterologist, all ready to go and do his procedures. He is a young guy, so he can go and do that. So let me just show you that, when all of this COVID coronavirus started, everybody thought that, we all thought the lungs have been the main focus, but it soon became very apparent that that cardiac implications or cardiac complications, heart damage is also occurring. And these are some articles that came out in the New York Times, etc. So the heart became important. Moreover, when you look at the first publications from Wuhan in JAMA Cardiology, they became very clearly to say that COVID-19 mortality was 50 times higher among patients that had a cardiac injury. And those cardiac injuries happened in about 50% of the time. And if you look at the cardiac injury and mortality, you can see that the mortality occurs when you have, much more frequently, when you have acute respiratory distress or when you have a cardiac injury. Now, when you look at the fatality rate, which is essentially the number of deaths divided by the death of those with a diagnosis, there are a lot of sort of changes between countries, but what is uniform is the fact that the majority of the cases are occurring in patients that are slightly elderly or over the age of 70. And this has been sort of shown very nicely in JAMA, in the JAMA Cardiology, in which you say that between 70 and 79, the fatality rate is 8. In patients that over 80, it gets much higher. So I think we all also now understand that there are many comorbidities that are associated with this disease, and you all have read about hypertension, diabetes, coronary artery disease, and COPD. And you can see again that the mortality is much higher when you have these comorbidities. So I think we also have learned quite a lot about, in one of the last circulation papers, we know that this COVID virus has these attachment protein spikes, and that these attach into this angiotensin converting enzyme receptor in the host cell. And these get activated by another sort of protein. The important thing to understand is this angiotensin converting enzyme inhibitors are not only in the airways and lungs, but they also happen in the cardiovascular system and in the vascular system. And that is the reason why we're seeing all of these cardiovascular problems and also thromboembolism in many of these patients. In fact, they are sort of describing that the myocardial dysfunction or the myocardial injury in these COVID patients occur in two sort of phases, or due to situations. One is myocardial dysfunction because the virus goes inside the heart. And the other one or situation is that because you have this host inflammatory response, you have these cytokine storms that create this inflammatory response, creating again cardiac failure or ARDS and so on and so forth. So this is sort of what we all learned. And as a consequence of all of these cardiovascular complications that are occurring, that mostly are arrhythmia or myocarditis, acute coronary syndrome, venous thromboembolism, or heart failure, every patient that demonstrates any of these things the American College of Cardiology has said that they should have an echocardiogram. So doing an echocardiogram in these patients, when all of this started, became complicated in a way, because you understand that when patients sneeze, these micro aerosol droplets can extend themselves up to 6 meters. When you cough, they go up to 2 meters, and just by inhaling or exhaling, they can go up to 1.5 meters. So when you do an echo, it is a complicated thing, because you're the sonographer or the physician, in case of places where they don't have sonographers, you have to sit in front of the face of this patient for maybe half an hour to obtain this patient. So it became apparent to me that if available, sonographers should have the protective gear in order to do those studies. So, the gear, in my opinion, are these masks that you have all heard about, this N95 masks. You need to, of course, have a shield, as you can see here. Then you need to have gowns, and you need to have gloves. And this is something that we took quite a lot of time to explain the sonographers how to have to use this gear. Everybody had to be fitted to get this mask and to have it correctly done. This is, again, the other thing that we implemented is that our hospital, half of the hospital is a COVID hospital. In those units, we actually placed an echo machine that would not come in and out of that unit. So we are lucky that we have enough echo machines that we can do it. So the echo machines were left in these COVID units. The other thing that we did is that when a patient was actively coughing and so on, we also placed a mask on the patient. This is just a regular surgical mask. So that is the sort of protection that we used for our sonographers. Of course, you all have heard of what has happened in Italy and also in the United States. There was a lot of situation that we were running out of supplies. Thank God, at the University of Chicago, we were very lucky that we had complete supplies. So we had the ability our sonographers used the N95 mask and the shields and all the PPE, all the protective personal equipment for patients, of course, that were COVID positive, but also for patients that are what we call PUIs, which are the patients under investigation. So all of those patients, we had the ability to use the sonographers to use the complete gear. Now, after visualizing a lot of these echoes, I can tell you that mostly you can divide what you're going to find in one of these 4 situations. The vast majority of the echoes that we see are patients that have a hyperdynamic function. This at least is my experience, okay? Sometimes they have a small left ventricular chamber and maybe you need to optimize the volume status post-intubation, and that's why they are so hyperdynamic. There is another subset of patients in which you have predominant moderate right ventricular dilatation. Many times I find it to be associated with the amount of PEEP that you're using with a mechanical ventilation. I have seen only few cases of left ventricular failure or of myocarditis. Many of these patients have difficult cardiac windows. Many of these patients in Chicago are obese. Many of these patients you cannot mobilize in the bed, particularly if they are intubated and so on. So we many times find that we obtain subcostal views. We do a focus study. We tell sonographers to do a focus study looking at the LV and RV function, looking at pericardial effusion. And we don't use an EKG when we do these patients in order to minimize the contact. We also don't use contrast in these patients in order to minimize the length of that particular study. Many of these, this is one of our patients. You can see that, these are all the, the lung findings that you would expect. You can see how this poor patient, things got worse in just 6 days. So I think this is a very good opportunity for all of us to learn how to do a lung ultrasound, because I think it can be very, very good. You can see in this example, you have this consolidation here with associated areas of white, telling you that there is consolidation. And you can learn this very, very quickly. The European Association of Cardiovascular Imaging has a very beautiful webinar that is given by a physician from Chile that is phenomenal. So I would encourage you to read it and to start using it. In these particular patients, this becomes extremely useful. So whenever you see these particular areas of white here, these are areas that are associated potentially with consolidation. Now, of course, the United States, like all over the world, or many places of the world, practice this isolation, and in which in Chicago, this worked very well. Patients stayed in their houses and did not go. You could actually go if you have a dog, you can walk your dog, or people who like to exercise, you can do that, or you have to go to the supermarket. But this was extremely good in Chicago because by doing the social distancing, we never got our system overwhelmed like what happened in New York. And these are just some examples. This is a very touristy area in Chicago. The Bean, whoever, you can see that there's nobody there. You can see here people waiting to go into a supermarket, and you can see that they are sort of separated by time. And in these curves, you can see this higher curve here is New York, but you can see here in red is Illinois. So we actually did a very good, the governor of our state instituted the social distancing very early, and you can see that we actually did not, Illinois did not peak as much. So this is in the midst of this is me going to the hospital and taking a picture, and you can see here that there are 6 ambulances bringing COVID patients. We never see that. So so these ambulances were still waiting to go into the emergency room. Now then you can start thinking what happens to our echo labs in the pandemic. And you can see here, we were usually doing, these are the total amount of echoes. We were doing about 85, 90 echoes a day. And when this all started, the numbers of regular echoes went down to 20. And you can see that if you look at these, in green are the outpatient echoes, patients that were coming every day to get an echo from the outpatient. You see these went almost barely to 0. So most of the echoes that we're doing now are echoes on inpatients. And I think it's also, now we are trying to slowly, we canceled over 1,000 transthoracic echo patients. We're trying to invite them, and we're finding that patients are afraid and they don't want to come to the hospital to get procedures because the patients are perceiving that they're going to get sick when they come to the hospital. So that's going to be a problem. It's going to take a long time for all of our societies to get back to truly normal. We had the ability to publish our experience in the Journal of the American Society of Echo, in which we showed with a lot of detail how how these numbers were decreased. We did a lot of interventions because we looked and only did echoes on patients that were clinically really significant. Our chiefs of cardiology and chiefs of medicine actually did a very good job at communicating with all of us. And I'm sure the same as we're doing in this meeting, we used Zoom once and at the beginning twice a day to communicate with each other what was happening. I actually divided the staff of the Echo Lab into two groups. One group would come for 3 days and another group would come with 3 days to try and ensure that I would have a sufficient staff, because if somebody then got sick, all of that group would not be able to sort of come. This is the numbers of yesterday. They send us these numbers. So we have, as from yesterday, in our hospital at the University of Chicago, we have 130 patients hospitalized with COVID, 130 hospitalized with COVID, but still under investigation. It's 85. So you can see we have around 210, 220 patients. We have 20 patients on ventilators. Then they tell us how many. We still have 56 ventilators in use in the hospital now, and we have 83 remaining that are not being used. So I think our administrators did a phenomenal job at thinking, because if you add 56 and 20, we had in the hospital around 140, 150 ventilators. So that, we were never overwhelmed, though we still served a large group of our patients in a very good way. Let me just tell you that our hospital takes care of, we had up to now 19 patients die from COVID in our hospital, and 90% of these patients were unfortunately African Americans. So, there is a big disproportion of African American patients dying, and that is predominantly due to the fact that they get poor medical care, and they have a lot of these obesity and diabetes, and all of these types of problems are more prevalent in the African American population. And this is just to show you, we were shown every day by our administrators exactly curves of what happened with discharged patients, how many died that day, what was the floor status, the ICU status. So I think enhancing the communication was extremely useful, and every group then participated in making their own plan. I was yesterday extremely happy. This is a funny story. This went viral yesterday as something in social media about this medication, remdesivir. This is a medication that has been studied at the University of Chicago. And apparently this medication, which blocks a particular enzyme that is required for the coronavirus to replicate, maybe is going to be useful. And they said that the person doing this study in our university said that the best news is that most of our patients have already been discharged, which is great. And patients that took this medication, we have over 100 of them, only 2 of our 19 patients died. So this is very encouraging. I don't think that the university really wanted to release this, but this was leaked out by somebody to the press, and this became viral. I'm sure that our chiefs of medicine would not have wanted that to be, but in a way, this is good news. If this really works, it's great news, and if it is good advertisement for the University of Chicago Medical Center, it is always welcome. So I'd like to thank you. I think that, when you think about the COVID, we talk about, how thankful people are to the nurses and the physicians and the people who clean and the people who bring the food and all, and the first responders, the police and the firefighters. I also think that our our sonographers in the United States that we have, these also are the unsung heroes of this pandemic, because echo was extremely important in this to make a diagnosis, and they were in the front line. So they deserve to be with the superheroes. So thank you very much for your attention.